Hi everyone, good morning, and I'd like to thank the organizers for inviting me. It's a great honor actually to be here. Let's have a look at the first slide. So here's the title I got, What's New in Hypertriglyceridemia? Insights from Genetic Studies. That's quite a title. And here are some papers. I'm going to go through all of them, of course, so how many hours have you got? No. This is just sort of some of the papers that have dealt with mutations in various triglyceride genes and risk of coronary disease. And they all find what we expect. I think that there's a causal relationship between triglyceride-rich remnant lipoproteins and risk of coronary disease. But then, of course, there's the problem that triglycerides are always inversely correlated with HDL, so the genetic variants, of course, have effects on both of these types of lipoproteins. So the question is, which of these are causal? And I think there are two papers actually which deal very elegantly, I think, with that. One is from our own group by Annette Warburg. And what she did here was she looked at the hazard ratio for ischemic heart disease. You can barely see it down here, per 1 millimolar increase or decrease in either of these types of lipoproteins up here, and also a ratio here. And she first looked at it observationally, and then she looked at the causal genetic estimate. And this is an instrumental variable analysis, so it's the statistical way of looking at causality, basically. And first, you see the observational estimates. They're all to the right of 1, so they signify an increase in risk. When we then look at the genetic estimates for the same increase in the lipoproteins, you will see that for remnant cholesterol levels and for the ratio here, and for LDL cholesterol levels, they're all the genetic estimates are again to the right of 1. So there's an overlap, if you will, here, while the only estimate that becomes insignificant is for HDL cholesterol, suggesting that the causality here is the triglyceride-rich remnant lipoproteins, and more specifically here, remnant cholesterol. And there's another study by Doe et al. Published a little later here, and it used a similar, slightly different approach. It used genome-wide 185 SNPs, but if you look at the results here, you'll see that when you adjust the genetically unadjusted levels here with the genetic estimates for the other lipoproteins, then again you see that there's overlap here between the genetic and the observational estimates for triglycerides and LDL cholesterol, but not for HDL cholesterol. So basically the similar results. However, if you're interested in drug targets, it's something slightly different. I'd say you're interested in, it's not only associations, what we see here, or causal genetic associations, but what you're interested in is you're interested in genetic variation in the target, in the gene that encodes the drug target, basically. And this is usually inhibition, right, you're interested in. So genetics variants in the gene that encodes a drug target, and if you're talking triglycerides, you're interested in genetic variants that lower triglyceride levels. Now, if these same genetic variants also associate with effect on disease, in this case cardiovascular disease, in the expected direction and doesn't have any adverse effects, and this is on-target adverse effects. You cannot look at off-target adverse effects with genetics, but then it's likely that this could be a good drug target. So that's what you're after, actually. The candidate genes here, the obvious candidate genes when you're interested in triglycerides is, of course, the lipoprotein lipase pathway. And that's shown here. I've stolen this and adapted it a little from a paper in New England Journal of Medicine. And here's lipoprotein lipase, here's GPI, HPB1, and here are all the other proteins, or some of the other proteins that modulate the effect of lipoprotein lipase. So those that stimulate lipoprotein lipase, ApoA5, ApoC, ApoC2, GPI, HPP1 to a certain extent, and then of course those that inhibit, which in this drug sense are more interesting. That's ApoC3 and the adipocrines, angiopoietin-like protein 4 and 3, and possibly angiopoietin-like protein 8. So if you are interested in drug targets, you will not be so interested in ApoA5 and lipoprotein lipase, or for that matter in gain of function variants in LPL, because it is much easier to design something that actually inhibits, right? So you are interested in genetic variants that mimic the inhibitory effect of the drug. So the interesting targets are ApoC3 and the angiopoietin-like proteins 4 and 3, and possibly also 8. These are the low-hanging fruits, of course, I think. You know this, these are old papers now, but this was sort of the first genetic triglyceride evidence, so I'll just go through it because I think it's interesting. One of the papers was from our group, the other was from an American group as shown here, and the results were remarkably similar. So we looked at loss of function mutations in ApoC3, and first of all, both papers found an around 39 to 40% reduction in triglyceride levels and also in remnant cholesterol levels for these loss of function variants, and a corresponding about 40% reduction in risk of ischemic vascular disease and also ischemic heart disease. So very similar results. And of course, not much later came the Antisynth inhibition trials of ApoC3 lowering in patients both with chylomicronemia but also with a more broad variation in hypertriglyceridemia. And in this study here, actually the patients incorporated had values from around 2.5 millimoles per liter to around 23 millimoles per liter, so quite a span. And if you look at the distribution of non-fasting triglycerides in the Copenhagen general population, this would correspond, in fact, to the entire tail of the distribution. So here you are looking at individuals who are certainly at risk. And here's the effect on ApoC3 levels and on triglyceride levels of these ApoC3 azoles. And you can see that ApoC3 was reduced down to by 75% in the highest dose here, as was the mean triglyceride level, so quite a large effect. However, you always have to look at effects and side effects, of course, right? And there were the usual, not so important effects here, but there was also a reduction in platelet counts as seen for some other azoles. And it's said that this is now prevented by GalNAc conjugation, but I don't know actually where we stand right now with that. But let's move to some of the adipocrines, angiopoietin-like protein 3. So here's the first study. Now we are way back in 2010 here actually. And this is a study by Musunuru et al. Published in New England Journal of Medicine. And this is a family study, actually. So they had a family here where they had these family members had a loss of function mutation in ANGPTL3. And here's the LDL cholesterol levels, the triglyceride levels, and the HDL cholesterol levels in these families as a function of the number of mutant alleles. And what you can see is that there's a really large reduction in LDL cholesterol levels from those who do not carry the allele to the homozygotes. The reduction is large, right? It's from 100 milligrams per deciliter down to around 30 over here. There's also a very large reduction in triglycerides down to a level of around 15 or 20 or something like that in the homozygotes. And there's also a reduction in HDL cholesterol, but only in the homozygotes. We then move on 5 years here, actually, and this is the Regenerative group, and they used the ANGPTL3 blockade with a human monoclonal antibody in this case, and they showed that this reduced plasma lipids, more specifically plasma triglyceride levels and non-HDL cholesterol levels in dyslipidemic mice and monkeys. And if you look at the curves here, you can see that it's quite a large reduction in triglyceride levels of about 80 or 90% here. Less here. And then finally, a couple of years later, we have some more recent studies. This is association of loss of function mutations in ANGPTL3 with plasma lipids, and this is a paper by Jonathan Stitchell, published in JACC actually. And what they show here is that for these loss of function variants, there's a 11% reduction in total cholesterol, a 12% reduction in LDL cholesterol, and on top of that also a 17% reduction in triglyceride levels. So if I were a drug company, I think I would put my money on this, right? Because these loss of function variants suggest that a drug would lower not only triglycerides a lot, but also LDL cholesterol levels. And here's risk then. And this is a meta-analysis, so you can see that there are a lot of studies that have gone into this meta-analysis, and some of them are not so large. But the fixed effects model down here shows the end result, and the end result for these loss of functions mutations is 34% reduction in risk. And again, we have to balance the effects with the side effects, and I'm not aware of any side effects here. I've not heard about any side effects. That doesn't mean they are not there, right? ANGPTL4, another adipocrine. This is a really old study, 2007, and this was a study by Helen Hobbs and Jonathan Cohn, and I was a co-author on that study because the Copenhagen City Heart Study was incorporated in that. But basically, this is a single variant in ANGPTL4. It's a sort of a semi-rare variant. It's called E40K. You will hear about that many times later in the talk. But already here in 2007, we could show that this variant was associated with a 36% reduction in triglyceride levels. And it, of course, also probably had a small effect on HDL cholesterol levels. And it was more or less the same in the two other studies, the ERIC study and the Dallas Heart Study. We then move on about 10 years, as you can see, and we have two studies here. The study from the Regenerative group inactivating variants in ANGPTL4 and risk of coronary artery disease, and a back-to-back study here from the myocardial infarction genetics and the cardiogram exome consortia investigators, also dealing with mutations in ANGPTL4 and a number of other genes, as you can see. But let's look at the data from the first paper. So first, they looked at association between the same variant as I showed you from 2007, namely the E40K variant, and other inactivating mutations in ANGPTL4. So here's the E40K variant, here's the triglyceride levels, and there's a significant reduction, as you can see. There's also an increase in HDL cholesterol levels. There's nothing down here for LDL or total cholesterol. And then the rare variants, so the rare loss of function variants where they have summed all the variants up, you see sort of a similar pattern, a reduction in triglycerides and also an effect on HDL. Though something that I think is a little odd is that this reduction here is actually similar to the heterozygotes over here. And then the risk estimate down here, I don't know if you can see it, but the E40K mutation, a 19% reduction in risk, and the other mutation, around a 40 to 50% reduction in risk for the more rare loss of function variants. The other study showed more or less the same. They also looked at this E40K variant. They showed about a 14% reduction in risk of cardiovascular disease for this variant, and about a 50% reduction in risk for the rare loss of function variants. But you can see there are not many carriers here. And then again, the Regenerative group, they looked at the effect of a monoclonal antibody, this Regeneron 1001 monoclonal antibody, and inhibition on serum triglyceride levels in mice and monkeys. And you can see that in mice homozygous for human ANGPTL4, this monoclonal antibody could reduce triglyceride levels significantly. Also in monkeys, normal lipidemic monkeys, in monkeys with hyperlipidemia, and in a single rhesus monkey with hypertriglyceridemia. However, there were problems here. There was a side effect in the animals, and this has been shown in knockout mice and in antibody-treated mice and in monkeys in preclinical studies. And the side effect is abdominal lymphadenopathy. And although this has not been found in humans, we don't really know whether that's a problem. Here are some completely new studies, I have to say, and this is a study again from the Regenerative group published in Nature Communications, and it deals with risk of type 2 diabetes and ANGPTL4. And what it shows is already here in the title. It shows that genetic inactivation of ANGPTL4 improves glucose homeostasis and is associated with reduced risk of diabetes. And the study includes human studies and functional studies and a lot of mice studies. I'll not show you all that. Here are the human studies, and this again is a meta-analysis of a number of different studies, and the endpoint is risk of type 2 diabetes. And basically you can see that again we have the E40K variant in ANGPTL4. It is associated with an 11%, so limited reduction in risk of type 2 diabetes with a lot of variation up here. And then they also looked, of course, at loss of function variants in ANGPTL4, so more severe mutations. And I have put the odds ratio down here because they don't talk so much about that, probably because the significance is 0.04. But at any rate, the odds ratio was 0.71, so a 29% reduction in risk of type 2 diabetes for loss of function variants in this gene, suggesting that this could be an important type 2 diabetes gene. What also, here's just one more slide from that paper. Something that I thought was quite interesting was that they showed that in knockout mice, ANGPTL4 knockout mice, these are the normal mice, these are the knockout mice. First of all, the liver weight was decreased in the knockout mice compared to the normal mice. And over here you can see that the hepatic triglyceride content in these knockout mice is substantially reduced. And you can also see it here on the histology. This is the normal mice. Red is fat, right? Red is accumulated fat. So apparently also a reduction in liver fat. So this is also a completely new study, and the reason I'm showing you this, you'll have to read it because it's a large study and it's quite complicated, but it has some new approaches, I think. So I just want to tell you some of the results here. So the study is called Genetics of Blood Lipids among 300,000 multi-ethnic participants of the Million Veteran Program. So it's a program in US veterans, basically. And what it finds is it shows that a total of 826 independently associated lipid variants across 118 novel and 268 previously identified genetic loci. So it basically identifies 118 novel loci which are lipid associated. So it's if you will, among other things, a very large GWAS study. However, if you look at the variants explained on these lipid traits, so the traits are total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. The variants explained by the old loci, so these loci here, lies between 7.5 and 10.5%, right? Depending on which lipoprotein you're looking at. And when you then add these 118 novel loci with a lot of new variants, then you move from this to 8.8 to 12.3%. And that's not a lot. And that's not going to be clinically relevant, I think. Then they use a genetic risk score of the variants, and they find out, which I think is also, of course, very intuitive, that if you use more than one lipid measurement, there are several of these individuals who have more than one lipid measurement, then you explain a larger fraction of the variation. And that's, of course, because you determine the level better, right? And then they do something that they call a PheWAS, so a phenome-wide association study, if you will. But in reality, what they do is not that fancy, I think. They use 65 unique ICD codes, so they go into the registries and pick out the ICD codes on the patients here, and 5 lipid-associated genes which are currently targeted by drugs or trying to be targeted, ANGPTL4, PCSK9, and a couple of others. And what they find here is that, again, the E40K variant in ANGPTL4 is associated with a reduction in type 2 diabetes, and that the well-known PCSK9 R46L variant, which reduces LDL cholesterol and reduces risk of coronary artery disease, also associates or causes a reduction in risk of abdominal aortic aneurysm. But that's perhaps not so surprising given that that is an atherosclerotic disease mainly. But here's what I really want to show you. They also find a new triglyceride gene here, and that's kind of interesting. The gene is PDE3B, so phosphodiesterase 3B. And it's the first variant they find is a loss of function variant because that's what they are looking for. And then they look at the effect on lipids and coronary artery disease, shown here. And first, in 2 studies here, HDL cholesterol. Unfortunately, the units here are used are standard deviations, and that doesn't make so much clinical sense because you don't have a value here. So HDL is increased with this loss of function variant, as you can see, and triglycerides are markedly decreased. Actually, this standard deviation down here corresponds, you can see that in the text, to about 43 milligrams per deciliter, so minus 43 milligrams per deciliter, or half a millimolar. And they then look for other loss of function variants in other studies, and they find a reduction in risk for these loss of function variants for cardiovascular disease of 24%. And I think the interesting thing about this gene here is that the PDE3AB is 2 isoforms of the same gene, are a target for something called cilostazol, and some of you may know what that is. It's something that's used for, it's actually used for claudication, intermittent claudication, and it's also used after coronary artery disease surgery to inhibit platelets. So that's quite interesting, although I can also see that you should not use this in heart failure, then you kill the patients. So I think the future of genetics is very much in the polygenic risk score prediction in clinical care, and I think we have to be careful here, right? This is some completely new data, but on a different endpoint. This is Gallstone disease. It's from our own lab. It's a medical student who is the first author, and I'm not the last author. It's Stefan Stender who's the last author. And we made a simple risk score, and we identified 6 new loci for Gallstone disease, so that more than doubles the number of known loci, actually. Here's the genetic risk score for the 19 variants, actually, here. And here's the risk of Gallstone disease for the same variants. And as you can see, in 1% of the population who have a risk score that's above 2.5, the risk is 5-fold increased. And that's actually clinically relevant compared to those guys down here. And in more than 10% of the population, risk is between 3 and 5-fold increased. This is from a supplementary figure from this paper just published in Nature Genetics. It came now in November, actually, and it's by Coronary et al. And the reason I show you this is because I really want to sort of temper the enthusiasm about how many SNPs you look at. So the paper looks at genetic variation and CAD prevalence, so the prevalence of coronary artery disease. These are some older studies, and this is the current study where they looked at 6.6 million SNPs and the effect on an endpoint called coronary artery disease, which could be many things, right? So that's one thing. And here there's no selection, so this is just all SNPs. There's no p-value used here, right? And this is CAD prevalence. Here's what happens if you use only 15,000 variants, and here's what happens if you use 50 variants in the same study. And my conclusion is a little different from the conclusion in the paper, I have to say, because if you look at what you gain by using 6.6 million SNPs compared to the 50 variants, you can see that it's not very much, actually, right? So I think if we want to use this ever clinically, we have to think simple, actually. We have to think about what are the really relevant genes and what is the variance in these genes, and not a lot of things that sound very fancy but maybe are not very applicable, right? Okay, that was it. Thank you.